In the setting of cardiac arrest, this is not drug facilitated, it's a cold intubation. So what we have here is we have our endotracheal tubes, my lubricant, my laryngoscope, have my LMAs in case of failed intubation, I have my bite block and also my syringe for inflation, have my bag valve mask for pre-oxygenation. I also have my CO2 monitoring, have the monitor on, have my suction ready to go in case I need it. So I have my suction kit there, and have the position of the patient. So in the event of, to intubate, first we've got to select our tube. So we have, for our female patients, we have sizes 6 and 7 millimeters, and we have size 8 and 9. For male patients, obviously there's size into consideration there on what size you would use. For our adult patients, we have the Parker FlexiTip for our adults. We have the Kimberly-Clark microcuff for neonates, and we have the Covenant mammogram for pediatric patients. So what we're going to intubate this patient. So obviously I would pre-oxygenate for a couple of minutes first, look at my CO2 levels, look at my oxygen levels, pre-oxygenate, but for the purpose of showing intubation, we're just going to go ahead with the procedure. So what I will do is I will grab my laryngoscope, and then what we want to do is go to the right side and sweep across to the left with the tip of the blade in the follicular groove without hitting the patient's teeth, and pulling the laryngoscope toward in the angle of the blade. So I'll get my bougie, place, also I feel it going along the vocal cords. So bougie's in, and I'll get my assistant to get the tube. Also for this procedure, keep in mind that we would also use goggles and a mask, but so that you can hear me speak, I have not placed it on. So I'll get you to grab the tip of the tube, and we will place the tube in. So for a male patient, we want 22 to 24 centimeters at the lips. So we have that. So carefully remove the laryngoscope, and we will remove the bougie. We will inflate, and what we want is 20 centimeters of water ultimately for the tube. And then what we want to do is check for, so we want to check for bilateral breath sounds, and we also want to check for the CO2, check CO2 levels to check for correct placement. So to you and that. So we will listen for the breath sounds. Sounds. Okay, and then what we want to do is secure the tube to keep it in place. Some people use tape and some people tie it off, but just for this purpose we'll tape that down, and that's our ETT tube. So we'll pop this down. When intubated, we can come across some complications, and we can also come across an ETT cuff leak. Now, in that instance of a leak, we can have leaks around an intact endotracheal tube, can be due to cuff underinflation or malposition of the tube, and that can be due to coughing, tongue movements, inadequate sedation, ETT not secure, secretions, if the head is not in an extension position or sniffing position, accidental pulling of the tube, moving a patient, such as if we move a patient to put on a spine board stretcher, etc. Misplaced orogastric or nasogastric tubes, and excessive peak airway pressure. Now with cuff leaks we will hear gurgling and we will have decreased tidal volumes. So we want to assess the cuff pressure to make sure we have inflated the cuff sufficiently. Now with passive regurgitation, if we have passive regurgitation and we need to problem solve this issue, we can use cricoid pressure to prevent passive regurgitation, or to try and prevent passive regurgitation. We can also ensure the patient is in the sniffing position, and this also is a tool we can use.